We know that it is not the virus that itself causes the severe disease, but it's our own body's immune response through the many pathways that cause this. Hospitals around the country typically have designated COVID-19 units. As a hospital emergency room physician, I am most certainly not exempt from treating COVID-19 patients. We read and hear about COVID-19 pandemic every day in the news. It's a topic of every conversation. Treating those who have suffered from COVID-19 firsthand on the front lines has opened my eyes to a different perspective. I've learned a lot about COVID-19, and today I'm here to share with you my experiences firsthand treating COVID-19 patients. Hey everyone, I'm Dr. Jordan Wagner. I'm a board-certified emergency medicine physician, and on my show, I answer your urgent medical questions and clear up myths about certain deadly diseases. If you haven't already done so, please make sure you hit the subscribe button and turn your bell notifications on. That way you are instantly alerted when I post a new video. Number 1, symptoms are not linear. COVID-19 patients' symptoms are all over the place, from asymptomatic to cold-like to flu-like to strokes, heart attacks, and severe shortness of breath and difficulty breathing. Call a doctor or a hospital right away if you have any one of the COVID-19 symptoms such as trouble breathing, constant pain or pressure in your chest, bluish lips or face, or sudden confusion. Number 2, ER visit protocols have changed. Every time somebody comes into the ER in cardiac arrest or not having a heartbeat, we treat them as if they could potentially have COVID-19, and many times the patients do not make it. Any patient coming into the ER can have it. So many times a patient without classic COVID-19 symptoms come into the emergency department, let's say with chest pain or abdominal pain, and gets a workup, and something is found that is required for the patient to be admitted to the hospital. At that time, we get a COVID-19 test when they're admitted to the hospital to make sure we know what their status is, and then all of a sudden the patient turns out to be positive. We typically would originally only test for COVID-19 if the patient had obvious symptoms of COVID-19. Number 3, age of the coronavirus patients. The typical age of a COVID-19 patient varies. It's not just elderly patients who are admitted to the hospital for COVID-19. Yes, the people most at risk are the older population and people with multiple comorbidities, multiple medical conditions, including hypertension, diabetes, and significant obesity or metabolic syndrome. Obesity is a tough topic to talk about, but anybody who has a BMI that is elevated should seriously contemplate lifestyle changes, a healthy diet that can be sustained, and an exercise routine of some sort. 4, trends in admitted patients. A lot of times, patients with COVID-19 who require hospitalization have very low oxygen saturations. This is caused by multiple pathophysiologic pathways. But what we have seen is that these patients can tolerate much lower oxygen than we had previously seen before with other diseases. That's why early in the pandemic, patients were getting intubated left and right quickly to help support them, but we found out that allowing the patient to breathe while awake with high pressure oxygen significantly improves the patient's outcomes and prevents intubation or that rough plastic tube we have to put in the throat. Number 5, new routines. Every patient I encounter, I wear an N95 mask and safety glasses, and I don't take it off my whole shift. I learned that many patients do not wear their mask correctly still, most commonly not covering their nose, and second most commonly wearing it as a chin strap. Come on. Currently, still, there is no good medication to exactly treat this, but when a patient does get admitted to a hospital, we typically will treat with whatever's available. Antibiotics, remdesivir, zinc, vitamin C, Decadron, convalescent plasma, just to name a few. Number 6, it's not technically an airborne virus, but however, it behaves like one. Airborne versus droplet. Understanding that this virus is a droplet type virus. However, given the fact that it lingers in the air in certain situations, it behaves like it's airborne. Research shows that the virus can live in the air for up to 3 hours or even more, and it can get into your lungs if someone around you just breathes it out and then you end up breathing it in. It is still different from a traditional airborne virus that we currently know about. In some certain situations, such as being in an enclosed space, this virus should be approached, though, as if it is airborne. Number 7, humans' immune response is the key player. We know that it is not the virus that itself causes the severe disease, but it's our own body's immune response through the many pathways that cause this. These pathways cause the severity of the disease. And that is why we know currently that when someone has a severe disease burden, that a steroid actually helps because it reduces the body's inflammatory response and the inflammation response. Number 8, antibody tests are not accurate. Many people believe that if enough people had the illness, developed antibodies to fight it, and were immune to catching COVID-19 again, then we could quickly return to a sense of normalcy. In response, there were calls for widespread antibody testing. However, the big issue here is that the early influx of commercial antibody tests were highly error-prone due to the rush to put them out on the market. Scary that so many people who have had COVID-19 don't test positive for the antibodies using the current tests that we have. Number 9, duration of sicknesses vary case by case. I've seen some people recover and get healthy in 1 to 2 days, and I've seen patients take months of continued lingering symptoms, the worst being fatigue and shortness of breath. According to the CDC, the incubation period for COVID-19 is thought to extend all the way out to 14 days, with a median time of 4 to 5 days from exposure to symptoms onset. One study reported that 97.5% of persons with COVID-19 who develop symptoms will do so within 11.5 days of contracting COVID-19. Number 10, some symptoms are prolonged after recovery. Also, I've noticed some people who have prolonged lack of taste and lack of smell. As anyone who's ever had a cold knows, smell and taste are closely intertwined. So the loss of smell, which doctors call anosmia, may be diminishing people's perception of flavors. Respiratory viruses, including cold viruses and the flu, are known to sometimes trigger anosmia. Patients ask all the time, how long will this last for? Honestly, no one has a great answer right now. Sorry. The world has been battling COVID-19 since January 2020, and many states' cases are not slowing down. As the pandemic progresses, the medical community has acted like a sponge, absorbing knowledge of how the infection is best treated from each new case encountered. All right, that's been a quick COVID reflection with me, Dr. Wagner. Let me know in the comments if you have any other medical questions that you'd like me to answer. And as always, please make sure you hit the subscribe button and turn your bell notifications on. Thank you so much for watching, and stay healthy, my friends.